Thank you, Nitin, for this wonderful opportunity. I think it's a beautiful topic what you have chosen, the big fight as well as this thing. It's a very important dilemma I think all of us are facing. Should I dive in the blind, multifocals in mature cataracts? These are my financial interests. See, as you know, these white cataracts, you can term it, you categorize into three categories. Type 1 with the intermittent white cataracts, the mature white cataracts, and the hypermature white cataracts. Why I am telling this? Because in the first category, the interlenticular pressure is very high, and most likely you can get an Argentina flag sign. Okay, and if you get an Argentina flag sign, obviously you cannot put a multifocal lens. Am I right or not? So that is the reason why I want to categorize that. So initially on the slit lamp you find out, in my opinion, for whatever technology is available today and whatever techniques we have got today, I don't differentiate between an immature and a mature cataract as far as a multifocal. If the patient wants multifocal, if the patient, the other eye, everything is normal, then I would prefer a multifocal lens. And I have very good reasons to say that. Okay, what are the things you should check for before you put a multifocal lens? For that matter, check the pupils. Make sure that this patient has got fairly, because many times they have mature cataract, they are not very sure when they lost the vision in that eye. So they may have an underlying optic nerve or a retina problem. Check the pupils, get the rexis right. 100% you have to get the rexis right. Okay, if you want a multifocal lens, get the biometry right, which is very, very important, because in multifocal lenses, you need to get the bullseye consistently. How do you get the bullseye? If you are an optical biometer. If you have an optical biometer, okay, the optical biometer, unless of course you have IOL Master 700, it can penetrate near total cataract, but not total cataracts, white cataracts like this. You need to have, probably depend on your contact A-scan method or immersion. Immersion is probably better, and get the biometry right, because in a unifocal you can go this way or that way, but in a multifocal you have to be there right, because the patient is paying for it, and that's the reason why. Make sure the macula is fine. And consistent surgery is very important. You need to make sure your surgery is there, and day one the cornea is clear. Look for amblyopia. Look for anisometropia. Again, we have seen many patients, multifocal mature cataracts in one eye, and that eye will have high myopia. Please understand, this eye will have high myopia, the other eye will have hematropia. This eye will have 10 diopter, the other eye will have 24 diopter. And you know, that is a red flag sign for you. Okay, if you put a multifocal lens, probably the patient will become probably had amblyopia because there is anisometropia, and probably the patient will become very unhappy postoperatively. Exotropia also look for it as well. Prerequisites again: healthy cornea, healthy macula, accurate biometry, good rexis, no intraoperative complications are very, very necessary. Thank you very much. And Pearl 1. Okay, the Pearl 1 is a constant A-scan contact method. Okay, what are the fallacies of A-scan? These are cons. Okay, the A-scan is not a very reliable method. I am talking about the contact A-scan. It's not a very, because it varies from one optometrist to another, or inter-observer. Variance will be there, and the variability is, for example, if you press the cornea, what will happen if you press the cornea? You will get less axial length and more IOL power. Okay, instead of 20 diopter, you will put 23 diopter. In a monofocal lens, you can probably manage and talk to the patient, but in a multifocal lens, he will cut your head. Okay, he will decapitate you. So that is the reason why I think it's important that you need to be there. A-scan. Probably if you have access to immersion scan, immersion scan is probably a good way to go if you have the IOL immersion scan with you, because it is almost equivalent to an optical biometry. But if you have access to the optical biometry like what we have, like IOL Master 700, then this actually penetrates even a very, because it works in a totally different technology, swept source technology, and that is the reason why it's able to get a three-dimensional view of the eye. And this IOL Master 700 is fantastic if you have access to it. Probably even posterior polar cataracts, or almost, you can see this is almost a total cataract. If it's a very total cataract, very white cataract is very difficult. Near total cataracts, you can still penetrate. The advantages of the IOL Master is really wonderful, and it gives you the lot of data for you: the corneal thickness, the anterior chamber, lens thickness, the pupil diameter, everything, the white to white, everything is available in the IOL Master. Again, if you are not able to get any of these, please 100% you have to do a B scan. B scan has to be done for all mature cataracts. Otherwise, you will end up in a medico-legal problem. Please understand, you cannot say that I don't have a B scan. Okay, you should have a B scan for all the mature cataracts. But the B scan can give you a gross idea of the retina. It will give you a gross idea of the retina, but it will not tell you what is the status of the macula, what is the status of the whether there's any ERM or anything. For example, this patient had a BRVO and preoperatively, and this patient didn't have an RAPD, everything was normal, the other eye was normal. This patient had a BRVO and macular edema as well. And postoperatively, after putting a multifocal, we burnt our fingers. And this is, I think, probably there's thing on a VMT and a CME as well. So Pearl 2 is preoperative protocols. I give for all these, especially type 1 cataracts, I give IV mannitol, oral acetazolamide, peribulbar block, super pinky, good hypotony to make sure. And Pearl 3, use high molecular weight viscoelastics like a soft shell technique. Viscoelastics are available. It's available cheaply with all the Indian companies as well. Soft shell technique wherein you put dispersive and then underneath the dispersive you put a cohesive viscoelastic and makes the life easy for you. You can see here how I'm putting a soft shell technique, making this rhexis very easy, because these mature cataracts, the rhexis can run away, especially the type 1 mature cataract. You have to be very careful. So type 2 also it's possible, but type 3 is hypermature sclerotic. The rhexis very rarely runs away, but you can have an Argentina flag sign. You can see that soft shell technique is one of the important things. So capsular rhexis, use Trypan Blue under IR. Aim for small rhexis, double rhexis. You can use a 26 gauge, 30 gauge, 27 gauge. So this is one thing which I've done a lot of work on this capsular rhexis. You must have all seen my puncturexis technique. See, there is a pressure underneath the anterior capsule. The nucleus is bulky, and there is a pressure in front of the posterior capsule also, and the positive vitreous pressure. There are 4 components. Okay, if you put a 26 gauge needle or a 27 gauge needle into the front compartment, it takes care only of the front compartment. The other 3 compartments are still there. So the other 3 components are still there. So if you put for example, if you touch this, for example, this Argentina flag sign, and as soon as you touch it, it goes to the periphery. Okay. This is very dangerous. You can't even put a multifocal lens. Sometimes you can't even put a lens because the nucleus can go, it can wrap around, go around the zonules into the posterior capsule as well. You can lose the nucleus into this thing. You can use a 27 gauge needle. You can see here how I'm using a 27 gauge needle in this particular case and aspirating the front compartment. The front, it works in about 50 to 60% of the case. You can see how I'm doing that. I'm aspirating and decompressing our intralentricular pressure by means of a 27 gauge needle, and then going ahead with the rhexis. You can see here in the usual manner. It works many of the times, or you have access to Zepto is probably one of the ways by which you can get a consistent rhexis even in a mature white cataract. But if you have access to the femto, it's probably one of the best methods which I have access in all the mature cataracts. Why I am putting multifocal lenses? Because I'm having access to the femtorexis, which makes life easy. Only thing is, you look for skip areas in femtorexis, and many times it may not be a free floating thing. In a puncturexis, what you do is go underneath, go into the anterior capsule straight away, as if you are directing the phaco probe, bevel down. You don't use a Kelman tip or an angle tip, use a straight tip. You can see how I'm doing the punch there. Punch not only the anterior capsule, you can see I'm going all the way down. I'm having a continuous phaco power of about 50-60%, and the burst of phaco not only punches the anterior capsule, it also debulks, emulsifies the nucleus and debulks the nucleus and pushes the nucleus back. It takes care of all the 4 components which I am mentioning about. Again, you can see these are the parameters I use on a sterilized mission. Just use high vacuum and a good phaco power of about 40-50% punch as if you are going into the anterior vitreous. Don't go tangentially, go vertically down. Then you can see here how I am doing the puncturexis again. Okay. So Pearl 5 is vertical chop technique. What I am trying to vertical chop technique is, the vertical chop technique is probably the best method by which you can take care of this, because many of these white cataracts are very hard cataracts as well. Use a sharp chopper. I have devised a chopper which is available with Appasamy, and you can see the sharp chopper how it opens up the posterior nuclear plate and make the cataract into smaller pieces. Be careful in doing a hydrodissection. In a white cataract, sometimes it can be a very soft cat. Be careful in trenching. Sometimes you can vacuum, can open up the posterior capsule as well. If you have small pupil, always use iris hooks or a Maliguin ring or whatever it is right in the beginning of the surgery, and this thing. So this is just to show you what are the mistakes we have done. This patient had a diabetic maculopathy. Okay, when you have diabetic maculopathy in one eye, please understand that diabetic retinopathy is a bilateral disease. Okay, this patient had diabetic retinopathy, maculopathy in one eye. So other eye we put a multifocal lens. We burnt our fingers. You can see we did a B scan. B scan will not reveal a maculopathy. So again, so this is the patient. Again, the OD, right eye, you can see that after the surgery, we found out that the patient has got diabetic retinopathy as well. Again, you can see another patient with the ERM. ERM also is very difficult to pick it up on a B scan in a mature cataract. So this patient had a ERM. The patient was very unhappy with the multifocal lens. See that these are the cons of this the particular. So if the patient has earlier come to you a few years back and then come with the mature cataract, if you have know the history of the patient, it's probably no. So if you have a patient, this patient had a macular hole, and this patient had a BR view with vitreous hemorrhage. Sometimes a fresh vitreous hemorrhage, you will not be able to pick it up on the B scan. But the take-home message is, many of the multifocals, the mature cataracts, you can go ahead, you can see the synergy lenses which I'm using now very frequently for all these patients, and the long-term follow-up of these patients.